you, before Joe gets started, there's paper on the tables, and what we would like you to do is if you have something that you'd be interested in us planning for next year, a speaker presentation, let us know. We will collect those, and the program is really gets scheduled. We'll take a look at them and follow through as we can with anybody presentations. Now I'm going to turn the time over to Joe Greenwald. He's with Medtronic, which is 94 years since Rich got his CBS. And we think there have been some changes that have happened in the last few years that Joe might be willing to tell us about. I'll turn the time over to you.
Perfect. Thanks, Joyce. Okay. Is that too loud? Okay. Hi, I'm Joe with Medtronic. So I've been with Medtronic for, I think I'm coming up on 18 years. About half of that time, 10 years spent just DBS alone, the previous neurosurgery. So as Joyce mentioned, there's a lot of faces in here that I've met over the years, and some of you guys have DBS, some of you don't. I'm going to try to make this an education presentation, not a Medtronic sales presentation. I just want to educate everybody on DBS and kind of talk about all the changes that have happened throughout the year. So as I kind of go through this presentation, if you guys want to just interrupt me, I'm more than happy to answer questions as we go so we don't forget about them. So don't feel like you have to save them to the end. And then with that said, also, this is a brand new presentation, so kind of work with me. I'm not as good on this one as I was with our past one. With all the new technologies that's kind of came about, we kind of refreshed this recently. So you guys are my guinea pig test group, so you guys can tell me if you like it or don't like it. This one focuses a little bit on what Medtronic has, but I'll also kind of go into what everybody has just to educate you guys. There's basically 3 DBS companies, and I'll kind of talk about all the changes, and each one offers something a little bit different. So it's kind of a conversation between you and your provider on which one might be more beneficial for you, okay? So DBS, today, it's for Parkinson's disease. We're using it for essential tremor, which is more of an action tremor. So obviously folks here are more interested in Parkinson's disease, but an essential tremor is when you go and you get a tremor when you get an action tremor. So you go grab your cup of coffee and then you start shaking, versus maybe more of a, tremor as you're sitting and your pill rolling tremor, et cetera, that you typically have with Parkinson's disease. It's also used for obsessive compulsive disorder. We're using it for epilepsy. We're also starting to use it for some addiction therapies. Some of this is all off-label, but there's all sorts of different things that people are using deep brain stimulation for. And the difference is, and why it works, is we're just targeting different spots in the brain. So different areas of the brain help with different things. So for movement disorders such as Parkinson's, there's 2 essential targets that we're using. For essential tremor, it's a little bit different of a target. For epilepsy, it's a different target. For OCD, it's a different target. And all we're really doing is creating an electrical current in that area, or disrupting the electrical signals in that area to provide therapy for y'all. Okay, so today here, what are we going to talk about? We're going to talk about Parkinson's disease, DBS therapy, when it should be considered, and then we start getting into brain sense, which is one of the new therapies that came out. We've probably been doing it. Adaptive brain sense we've been doing for about 3-4 years, and then adaptive was approved in the last year, and we'll try to go into that. Within that, we'll also talk about some of the other therapies that are out there and what they're offering, what you can expect from DBS, and then we'll kind of show a couple quick videos, question and answer, et cetera, okay? All right, so first thing here, audience poll. Which statement best describes you? You know a little bit about DBS. I'm seriously considering DBS, or a loved one already has DBS. So how many people know a little bit about DBS? Okay, who knows nothing about DBS? Okay, who has DBS if you don't mind sharing? Okay, perfect. So a few of y'all. So any of the folks that have it, and if you're not shy, please don't hesitate to stop me and tell me that's baloney. Tell me, yeah, that's true, or share your experiences, because obviously I haven't had DBS. I've watched hundreds and hundreds of surgeries and been a part of hundreds of them, but I'm not the person living with it. So you guys can probably offer a little bit more than I can. All right, so I'm going to start with the quick video here.
After the device was in, they turned it on. We were able to find settings that worked for me right away, but it didn't really impact me. I want to say until I watched the video, where you could see my hand shaking, and then a few minutes later, nothing. And so seeing it in the video, I got emotional. You know what I mean? I got to a dark place, and I found myself, you look around and you ask God, am I gonna get 5 more years? Can I get 10 more years? And we start to make, bargains. And it just felt like an answered prayer.
Okay. So first off, I'm going to start off, before we go to this next slide, just familiar with Medtronic. Okay, few of you are. So Medtronic is the largest medical device company in the world. They got their start, they invented the cardiac pacemaker. So that's kind of where they got their start. And then through time, we're involved in all sorts of different therapies, from cardiac to neurosurgery to diabetes to spinal implants, all sorts of things. But my passion and why I'm here today is obviously to talk about deep brain stimulation. So myth, we kind of read this here. Every person with Parkinson's disease experiences the same symptoms. That couldn't be farther from the truth. Everybody has different symptoms, different issues, etc. DBS helps with some of these, but not all of these, okay? So tremor is something a lot of folks have, but not all. And that's something deep brain stimulation will help with. It helps with slowed movement. The fancy term is bradykinesia. And then it helps with stiffness and rigidity. Those are kind of the 3 things that DBS is going to help with. And how many folks here are taking Cinemed or levodopa or something along those? DBS typically helps with the same symptoms that you're getting relief from those meds, okay? If those meds are no longer helping, DBS most likely won't help you either, assuming that it's not just a med change that you're needing or an increase, okay? So back in the olden days, we used to use DBS as kind of a last resort. We do it if we've kind of tried all the meds and now nothing's working anymore, let's do DBS. And that's kind of switched the other way now. Now we do DBS a lot earlier because studies have shown people have a better quality of life if we do it sooner rather than later. All right, so Parkinson's, like we talked about, it impacts everybody different, from tying your shoes, drinking a cup of coffee, cooking a meal. So medications have limitations, right? So people that are taking meds, as time goes on, you're increasing your doses or taking them more and more often or more frequently throughout the day. You're having more fluctuations and you're getting side effects such as dyskinesias. So is everybody familiar with dyskinesias? It's kind of what we see with Michael J. Fox all the time, all those kind of movements. So an increase in dopamine, increase in medicine causes that. And so the advantage of deep brain stimulation is you've got your on time where you're feeling good, you've got your off time where you're not feeling good. We're trying to make that more even throughout the day. So taking less doses of medicine potentially, and having DBS kind of even out and then take meds as needed. So you're more having a day like this instead of a day like this. Because what we've heard is a lot of people kind of plan their day based on their on times and off times, right? So you're gonna go do your activities, the store, et cetera, when you're on. And then when you're off, some people rather be at home, et cetera.
Joe,
Yeah,
I'm seeing the next slide. Can you turn that off? It is not on the screen, but it is on the computer.
oh, it is. Let's see here. Give me 1 second.
You're seeing the Zoomers are seeing the next slide.
Yes.
Yeah, it's okay. It might have to be that way for Joe to see his notes.
Let's see. Looking here.
Do you need the?
Hide presenter view. No, I can look up here.
Are you sure?
Yeah,
Okay.
is that still,
Yeah, that's good.
is that better?
Okay.
Yes.
Okay, and are you guys hearing me okay on the microphone? Okay, because I can't tell from here. Okay, let's see. All right, now, oh, there it goes, okay. Okay, so options. So most of you guys are seeing clinicians. So how many of you guys are seeing a movement disorder neurologist? Most folks? Is anybody seeing just their general practitioner? Okay, and anybody seeing just a general neurologist? Or maybe not sure, okay. So let's kind of talk a little bit about this keeps going on and on, it sounds like. Let me keep talking about the differences of the three. So a movement disorder neurologist is a neurologist that's got not just general neurology training, they've also got an additional 1 to 2 years in just movement disorder. So all they're seeing is folks like you that has the movement disorder such as Parkinson's disease, okay? Can you guys hear me all right if I'm not using it? Okay. No. Keep it going? Okay. Oh, you got a different one, okay. A neurologist sees people that have any sort of issue, whether it's a movement disorder or something else, they specialize in that. And then your general physician, they have to see everybody and know a little bit about everything, okay? So if we look at the state of Nebraska, for a movement disorder neurologist, so someone that's more specialized, you typically, for the Lincoln folks, have to travel because there's not one in town anymore. The closest one is either in Omaha at Nebraska Medicine, or there's one in Kearney, at Kearney Regional. But other than that, we don't have any more in the state. They're hard to find. They're in high demand as Parkinson's disease increases and other movement disorders do increase. So if you ever want a second opinion or a more specialized physician, that's a good person to see. So most folks that go and talk about Parkinson's disease, you have the discussion with your doctor as, okay, what do I need to do? Well, first, usually we start off with meds, right? And for a long while, depending on the person, meds work really great. And some folks will say they didn't even realize they had Parkinson's or feel like they had Parkinson's. As the disease progresses, things change and you're not feeling quite as good, and we're increasing meds or trying to do other things and looking at other options. And that's kind of when deep brain stimulation comes to the conversation, along with things like focused ultrasound. I'm sure some folks I've heard there used to be a gentleman in Nebraska City that was doing focused ultrasound, right? So I several folks that would ask about that. That was one thing. There's also pumps. So people that are getting constant pumps for their meds, that's another option. And then more important than anything, the only thing that really slows it down is exercise. So I'm sure that's been inbred in all of you is exercise, 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 right? But today we're going to focus on DBS, just because that's kind of what my expertise, if you will, is in. So another one of these myths and facts. My medicines or medications are good enough. The benefits of DBS won't be any better. As we talked about some slides ago, DBS can help with slowness, stiffness, and tremor, and may reduce your meds by about a third, okay? So there's a handful of patients that can completely get off meds. A handful. That should never be your goal. If you're one of those folks, you're lucky. But usually we can decrease it, right? So why is that important? A lot of people get side effects from their meds that they're uncomfortable, they're problematic, they get dyskinesias. So with DBS, we can eliminate some of that, right? So that's why it's important. Okay, so what is DBS? DBS, basically what we do is we put 1 to 2 wires in the midsection of your brain, if you will. They look like spaghetti noodles, is kind of the size and length of them, if you will. Then we put a battery. Hence how I told you earlier, we invented the cardiac pacemaker. The technology was based on that. It looks like a cardiac pacemaker that we'll typically put in the left or the right chest. And then between this and here, we have an extension cord wire that connects the two. And it's all underneath the skin, okay? The benefit of DBS is it's adjustable and reversible. So meaning, if they find and when they find a cure for Parkinson's, all we do is we shut it off. It's not going to impact you. It stays within you. If you so felt like it was important to take it out, we can take it out, but it doesn't harm anybody, just to leave it in there. And DBS, some folks that we've talked to say, well, this kind of seems, is this new? I've been doing it for 30 years. So it's long established. As I mentioned earlier, the FDA now allows us to do it even sooner than we were doing it years ago, just because of the benefits. So what are the benefits? Improved motor symptoms and more on time, right? So there's studies that show DBS increases your on time by about 5 hours a day, okay? Reduce medication, improve quality of life, and 24/7 therapy, right? So while you're sleeping or doing other things, we don't have to be taking medicine. DBS is going to continue to be on all the time. Okay? So who's a candidate for DBS? There's 4 main things. You've had Parkinson's for 4+ years. Why do we care about that? Because we care about people that have idiopathic Parkinson's disease. That's what we want to treat. We don't want to treat somebody that has a movement disorder or an atypical type Parkinson's disease that DBS is not going to help with, right? Your physician will know exactly which ones it can assist with and which ones you can't. There's 500+ different movement disorders, and we want to make sure that you're a candidate before you go through this, okay? 2, that you've had movement symptoms or medication side effects for 4+ months. That's the change right there. It never used to be that soon of the 4+ months. It used to be years, right? And that's what I was talking about, where the FDA clinical studies have shown how impactful this is to people's lives. Levodopa responsive, and you have symptoms that aren't adequately controlled by meds. So if meds are working just fine for you, this isn't for you yet. But start thinking about it, because it's brain surgery, right? It's scary, so you kind of want to start having those conversations, do some investigation, but it's not necessary to have it done yet. Okay. Considerations. DBS therapy does not address all symptoms. Okay, so this is what it doesn't help with. Freezing of gait. It's not going to help you with that. It's something that a lot of people still will continue to have. It's not going to help with the speech. You're still going to have to use speech therapy for that. Balance and cognition, it's not going to assist with. Okay? So again, what it does help with is tremor, rigidity, and bradykinesia. Those are the 3 main symptoms. Now, some folks have said, well, I feel like it's helped me in other ways. I can taste things better, things along those lines. Everybody's different. I've heard those things, but it hasn't been proven that it helps with those things yet, okay? So who may it not be appropriate for? The biggest thing is people that have established dementia, right? Because it can make it worse. How do we find that out? There's neuropsych testing we do beforehand to kind of test your cognition. And if there's some things that maybe aren't horrible but could use some improvement, we can also change the target in your brain. If you remember, I mentioned for Parkinson's, there's 2 targets we use. One of those is more frequently used if there's some signs of maybe some forgetfulness. Okay, but what we don't want to do is have you go in and we target an area that's going to make the dementia worse or your forgetfulness worse, right? Because now all of a sudden we've got rid of one problem that caused another problem, right? So we don't want to do that. Any sort of severe neuropsychiatric diseases, anything like that, the same sort of deal. We don't want to make anything worse. You're a poor surgical candidate. So if you've got all sorts of different medical things going on, that's when we probably wouldn't do it. A lot of people think it's an age thing. It's really not an age thing. I mean, I mean, we've operated on people, or I should say I have, we've seen people operated on that are in their upper 80s. I think even 90, I think is the oldest person I've seen get deep brain stimulation, but it's usually when you start aging, right? We start having cardiac issues or other sort of issues that may limit what we're willing to do. And is the risk outweigh the benefit type of a question. And then the last thing, if you're not responding to levodopa, it probably doesn't make sense. So I cover Nebraska, North Dakota, South Dakota, and most folks will say is if we go back to the different options like focus ultrasound, if you're not a DBS candidate, that's when most of them would start recommending things along those lines, right? Because you're not a surgical candidate, but something like that might make sense or be able to help you, or a med pump, etc. So this is the safety and effectiveness have not been established for. This is what I was talking about earlier. Patients with disease origins other than idiopathic Parkinson's disease, okay? So these are kind of the contraindications or the things that we may want to have a conversation with your physician because they may not want to do it or not be as comfortable with. And it's going to be more stuff that's maybe more experimental, right? So you don't have idiopathic Parkinson's disease. You've had a surgical ablation procedure. So that's getting into, we've removed something from one of the targets that we may use in your brain for movement disorder. So that might have been you had HIFU, we call it, high frequency ultrasound. You may have had something removed. Back in the day, people would have like different areas of their brain removed. And that would help with Parkinson's disease for a while, right? You're pregnant, you're under the age of 18, you have dementia, you got comorbidities or I can't say that, coag, so different blood issues, or severe depression. We don't want to make your depression worse. I said it, Ken, I think I said this earlier, people are using it to treat depression, a different target in your brain than we're using so for Parkinson's. So Parkinson's disease, if we hit the right area and you have depression, it could make it worse. But if you have depression and we're trying to solve it, we're going to go to a different part of your brain and stimulate that area, and it can actually help with your depression. Okay, so more on time. 2+ hours of more on time. If you're having that, dyskinesias, we're saying that's going to give you 2+ more hours. 5+ more hours without dyskinesias, okay? So that's two different studies. What most folks will say is, and what I hear most frequently, is the 5+ hours of more on time, okay? That's a big deal. If you think about your day and how well the meds work, if you can get an additional 5 hours, and we're not counting necessarily your sleeping time, that's pretty impactful for somebody's day, all right? So here was a clinical study that was done back in 2013, and this talks about what we saw a statistically significant improvement in: improved quality of life, improved emotional well-being, and improved activities of daily living versus just taking meds alone. So when DBS first came out, about 30 years ago, like I mentioned, it was kind of, last ditch effort, if you will. Let's throw this out there and do this. The meds aren't working anymore. Now, folks are getting it earlier and earlier, right? It's just the quality of life is so much better. And most folks will say, I wish I would have done it sooner. Once they get over all the scary surgical parts, most people are like, I wish I would have done it sooner. That's the thing that we hear most frequently. So when should you consider DBS? We've kind of hit on this a lot. It's not a last resort. We need to do it before the meds quit working. When's the right time? So here we are again. You've had your diagnosis, medications are working. Now we call it the window of opportunity. Medications are still working, but not as effectively as they once were. That's when you need to do it, and that's different for everybody. It's not an age thing, it's just a disease thing. Some folks, medicines last forever and do really well for a long, long time. Some folks we see they may work for a few months and then not so well. But once the meds aren't working, DBS is not a good option anymore. Okay. Are your Parkinson's symptoms impacting your daily activities? So this is kind of a checklist we see a lot of the physicians use to kind of indicate your off time. I barely notice I'm off. I have difficulty, but I can do all things I want. I can't do some things, and I can't do most things. This is what physicians will use a lot of times to kind of say, hey, are you being adequately medicated and or not? Okay. And then we start looking at dyskinesias. I don't have any. I barely notice them. They interfere with some activities and they interfere with most activities. So usually when we see folks, they come in for various reasons that they're going to get the deep brain stimulation. Some say I have horrible side effects. I want to reduce my meds. Some say the meds just aren't working as well as they used to. I need something else. Some folks will say I'm taking meds 8 to 12 times a day. Some folks are saying the meds are causing horrible dyskinesias. I can't live like that. So those are kind of the more common things that I guess we typically hear. And like we said, it's different for everybody. So here's the things again. Medications, how often are you taking them and how much? What are your sleep cycles? There's a lot of sleep studies going on, even at the University of Nebraska. Folks with Parkinson's don't sleep as well. I don't know if that's really a surprise or not, but they're doing a lot of research on what kind of DBS stimulation can we give those folks to help with their sleep, right? And then movement, we need to keep exercising. Even if you have DBS and you're taking meds, exercise. So now we're kind of getting into, that's kind of like the high level deep brain stimulation. Does anybody have any questions on that portion? And then I'm going to go into here, kind of some of the new therapies that are being offered for folks within the deep brain stimulation realm. Yes?
How does this process work with insurance companies? Or
Yep.
insurance company will cover this?
Correct. So the question is, how does insurance work with deep brain stimulation? Insurance, it's covered. Basically, the way insurance usually works, if Medicare covers it, then all the private insurance usually follows suit, and that's what's happened. So rarely, I can't even think of an instance where it hasn't been covered. Some insurance companies may take more time than others, but it's always approved, and we always make sure it's approved before you'd even go down that route. So no issues whatsoever with approval for deep brain stimulation. Any other questions? Yes. It does help with dystonia. It matters on what type of dystonia you have. There's a lot of different types of dystonia. Cervical dystonia, we do a lot of deep brain stimulation for.
But I have it in my left foot and my neck and shoulder.
That's a conversation between you and your neurologist. It kind of depends on the person and more history than I would know. So that's a conversation that you can have with them. But yes, and some of the things that you mentioned, it could help with. And others, maybe it's a question. The foot could be a question with your physician without knowing a whole lot. But the neck and stuff, it should help with. Do you see a physician for that or not?
My neurologist.
Okay, and a movement disorder neurologist or not?
No.
Okay, so that may be a good example of try to get a second opinion and why I say that, they're just more versed on these kind of questions and in-depth questions. And you can always just get a second opinion and continue seeing whoever you're seeing. Just because just think of a neurologist, they have to know thousands of different things. So that's why I always say it's always nice to get expertise from somebody that's specialized in something, right?
Question I have is I don't have a lot of tremors or shaking.
Yep.
I rarely do, but I have all the other symptoms like the rigidity and the slow walking and the hunching.
Have you been diagnosed with Parkinson's disease?
Yeah.
Okay.
My dad has it and the 2 siblings have. My dad died with it and I have 2 siblings that have it now.
Okay. Yeah, unfortunately, we still don't have a good way to, usually unless any folks have done anything different, typically what we see is they'll give folks a couple tabs of cinnamon and say, does that help or not? And that's kind of how we say, you have Parkinson's or you don't. There's not a good blood test or anything like that right now.
When the carbidopa's working, I feel good.
Well, good.
But when it a lot of times it doesn't kick in or it doesn't work at all.
Yeah, yeah, and that's, maybe get a second opinion or talk to your physician and let them know that and see, and I'm happy to talk to you afterwards too and, see what maybe they can do or help you with. Yeah. No, if you have Lewy body, it's probably contraindicated because that gets into some of the cognitive issues. But no, it doesn't slow that down or assist with that. Yeah. Another question back there, did someone have? No? Okay, so now I'm going to go into kind of the new stuff. So BrainSense Adaptive DBS. Okay, so this is all the new technology. So let me kind of back up. DBS, like I mentioned, was around for about 30 years. About 10 years ago, and it was only Medtronic, about 10 years ago, two other companies came into the picture. And not surprising, they're the same people that are in the cardiac space with Medtronic. It's Boston Scientific and Abbott, right? So we're all kind of in this space. And the great thing about competition is it makes everybody up their game, right? So all of a sudden, nothing was being done with DBS. It was working just fine. There was no new things. And then competition comes to the market and everybody started coming out with new little widgets or new little things that could potentially help. One of those was directionality. So with our leads that go into the brain, there's contacts. Historically, there was 4 contacts on each of those wires, and we would light up 1 or 2 of those contacts, and that would stimulate your brain and help with the Parkinson's disease. Well, the problem with that at times is you can get side effects. So wouldn't it be great if we could directionalize that current, right? And not hit those things that would give us side effects. So that was probably the biggest thing that came out of that. And so while that came out, we realized, and with a lot of these therapies, which everybody has directionality now, whichever company you want to use, we realize that on most patients, it's not really that important. And the reason I say that is this is why. But it does impact, if you're one of those patients that do need it, it is important, right? But we say usually like, 1 in 10 patients maybe would use a directionality, the other patients would be fine. The problem is we don't know which of those patients did. So now everybody gets directional leads. Doesn't matter which company. Everybody's that's just kind of the standard of care now, right? We're just gonna put it in there, we're able to do it. It doesn't change the surgery, et cetera. Just an upgraded wire that goes into your brain. But here's what I always tell people, and this is the most important thing with deep brain stimulation. We can talk about all these new features and great things that any of us can do, any of the companies. The most important thing is 3 things. 1, you've been diagnosed properly. You've got Parkinson's disease. And the Parkinson's movement disorder, that idiopathic Parkinson's disease or a dystonia or something that we can treat, that we know it works for. The second is you have a surgeon that can get that wire in the right place. That is so important. If we have a wire that's in the wrong place, it doesn't matter what we do to it, it's not gonna work, right? So we have to get it in the right place. And third is that we have a neurologist that knows how to program the device, that they know the tips and tricks to get that device programmed correctly. Because when we look at these programming of these devices, there's thousands of different programs. So you need somebody with the experience that knows how to program them. If you have those 3 things, it's going to be successful. Now, in Nebraska, with deep brain stimulation, we've been very, very lucky because we've had surgeons that were part of the largest study ever done for deep brain stimulation. There was a gentleman named Dr. Ken Follett that used to be here. Some of you guys that have deep brain stimulation may have been implanted by him. He's since retired, but he did the largest study. It was the VA study on deep brain stimulation. So we had him, and then he was followed by another leader in the field of deep brain stimulation. And then another one has recently came. So we've been very lucky in this area to have just very premier doctors for being not in a, New York City, Chicago, et cetera, where Mayo Clinic. We've just got phenomenal doctors that are cutting edge on this research for deep brain stimulation, right? And then we've got great neurologists that know how to program these devices. So that's probably the most important thing. But now we've kind of got, like I talked about, the directionality was the first thing that came about. Now every company is kind of hedging their bets on what the next thing is. What's what's going to be most impactful and beneficial for patients. So first I'll start with Medtronic. What Medtronic has done is come up with adaptive DBS. What is that? If you think about it, anybody have any sort of cardiac device here where they send over their signals over the phone or something like that, or you can do it remotely? It's kind of what DBS will do, right? So what DBS does is we can sense your brain signals. So that device, that battery computer in your chest records your brain signals, right? So we know what things look like and what that means to be. There's different signals that mean different things. Some mean tremor, some mean bradykinesia. We can track those signals. So now, not only are you coming into the clinic and I've got 30 minutes to an hour to see how you look, I can see what's going on all the time when you're at home, when you're off, when you're on. And then the next thing that's came about, so that was the first thing that we released a couple years ago. But now what we came out with, it adapts for you. So now when you're sleeping, it might turn it down. It might turn it up when you're out and about and you need more stimulation, right? So what that does is it helps even out your day and adjust automatically. And then two, it can conserve the battery some, right? Because we're not having to stimulate you as often. And when I say the battery is the one thing that has to be changed out every few years. All this stuff should stay the same unless, you know, you're one of the 4% unlucky people that have something go wrong here, an infection or something. The battery, depending on what you get, typically lasts 5 years, so rechargeable 15 years, okay? But now we're looking at your day-to-day activities and that stimulator is adjusting by itself. So that's kind of what Medtronic has done and put their investment into, okay? Another company has put their money into remote programming. So you can do a Zoom meeting with your physician and they can adjust it that way. And then a third company has gone with visual programming where they'll take a MRI that the patient has and they will they'll draw basically the anatomy and it will be like a visual programming. So it's kind of no company has everything. We've all just kind of invested our dollars differently on what we think is going to be most beneficial for the company, or for the patient in the long term. Okay, so again, how does it work? So basically what we do is we set up, this picture kind of shows, if you look at, we kind of do thresholds. So you have an upper threshold and a bottom threshold. We want you to be right in the middle, right? We want to make sure if you're going up too high, that may be you're overstimulated, you're getting dyskinesias. We need you to come back down. If you're below this line, you're off. You're not feeling quite as good. We need to increase the stimulation, right? So that's kind of what we want. If that top line and that bottom line, that's where we want you to ride kind of between. And that's what the adaptive does. It keeps you between those two lines. Okay, so the largest study on adaptive just got presented. There was just the Movement Disorders Society meeting in Hawaii 2 weeks ago. And two studies were presented there. And basically what they found is patients that were on the ADAPT therapy preferred it, and most of them continued to be on it. So what that told us was, one, they felt better, it was working, we can move forward with it. Okay, so that's kind of where we're at. And so as we talk about this, everything in medical moves a little bit slower. We are just now getting into this in the state of Nebraska. We are just now having clinicians adapt this and start using it on patients. So we started out, when Medtronic came out with this, we had about 10 sites across the US, all the big sites that you hear about, and they did studies on it, et cetera. And now we've kind of like, and even myself, I'm not an early adopter on things. I like to kind of wait things out before I start recommending things. And so we're now just thinking, hey, this has proved well for patients. Now it's time to maybe start trying it on patients. So what kind of patients would you try it on? We could try it on patients as they get it implanted right from the get-go. And then the other thing where a lot of people have interest is patients that were having trouble. They were doing great forever, and now all of a sudden things aren't going quite as well. Those are good patients to say, okay, let's kind of go back to the drawing board and look at ADAPT and see how we can help those patients. Because the other thing that we can do now with this brain sense technology is, I said there's multiple contacts in your brain. It will spew out which contact is the best based on these signals we're getting. So instead of us just kind of guessing with the physician what we think looks the best, anybody that's been programmed initially, they're going through. Here and there, the initial programming takes a while, and we're looking at each contact to see which suits you best. Now it kind of spits out which one, based on those brain signals, will be the best. And so now we can even go back to people that were implanted 20 years ago and say that don't feel like they're being adequately controlled, and look back and say, hey, let's go back and kind of start from scratch. Because even all the old technology we can do this with, as long as we have the new battery. All right, so all of our stuff's upgradable now. Nothing kind of puts you out of not being able to do this. Like I said, this is a new presentation, so I'm kind of skipping over some of these that I don't think make sense. Those are both just analogies on how ADAPT work. They were talking about it kind of setting your thermostat or being on cruise control. Both great analogies, if you will. Okay, so what to expect? The DBS procedure is too scary and not worth the benefits. So 95% of DBS patients would recommend it to family and friends. So this was a big study done with some very big names back in 2019 in the Journal of Neurosurgery. So like I said, most people that we hear from recommend it. So how does the surgery work? Every site is different, but I'll tell you how typically it's done. Typically, you'll go through, the physician will talk to you about it. Most of the physicians bring it up when they think you might be a good candidate. And then what they'll do is they'll send you in to do a neurocognitive evaluation or neuropsych evaluation. They'll do an MRI. And they'll make a decision to say, are you a good candidate or not? The University of Nebraska has a good procedure. They basically put you through this, and then they have a group where all of their movement disorder neurologists, their surgeons, their neuropsych group, they all meet, and they have to get an unanimous approval before they move forward with, because they're very conscious that anybody that gets implanted with is going to have a good result. Now, that can be frustrating because they're very stringent, or they might say, no, sorry, we don't think you're a good candidate, come back in 6 months. So it can be frustrating, but I always tell people, it's always good to have folks that they can't say they can do it tomorrow. That's not a bad thing, right? Let's kind of wait, and they have your best interest at mind. So they have a really thorough and a good way of doing things. So after that, you've done that, the board has said, you're approved, you'd be a great candidate. The first thing we do is a lead procedure. So that's the lead going into the brain. Typically, we do one side. It's changed over the years, and part of it is based on where surgeons were trained. Dr. Follett, when he was here, a lot of times we'd put 2 leads in the brain at the same time. The surgeons nowadays, for the most part, are putting 1 lead in the brain at a time. And it's based on how they were trained and some data that says, oh, it might be better to do 1 lead at a time for memory issues and whatnot. So different reasons, benefits to both, but typically now in the state, most folks are doing 1 lead at a time. Then you come back, do the second lead, and then you go home, and a couple weeks later, they put the battery in. Why is all that? So one, when you come in, you're off your meds. So that's tough for people, right? So we don't want you in there off your meds forever, because the thing that's kind of interesting for the inpatient lead placement, and what distracts a lot of people, is you're awake. So that's pretty scary, right? You're doing a brain surgery and you're awake. I will say, there's a new surgeon, not so new anymore, he's been here for 3.5 years, Josue Avesias at Nebraska Medicine, who does the bulk of the procedure is sleep, which a lot of people that were not considering it before are doing it now because you are asleep. So what he does is he puts you asleep and just wakes you up for the part that you need to be awake for, and then puts you back to sleep. So people really seem to appreciate that. Because I think the biggest hesitancy for most people is, I can't imagine being in a brain surgery awake, right, or any surgery. So that's been great, and his results are just as good as anybody that was doing it fully awake before. Okay, and it's just the method that he was trained in at Mount Sinai in New York, and it's he speaks all across the world on it. It's a fabulous technique that he does. So then you have the whole device put in, and when they put the battery in, you're asleep. And then usually 2 to 4 weeks after that is when you go get programmed to your neurology office. So you've gone through all this, and now you need to get it turned on, and that's when they'll turn it on. Okay? Yeah. You're off medication. No, just for the surgical portion. And the reason you're off, so the way the surgery works and why you're off and why you're awake for part of it is, so we go in and you have all these MRIs done, which is basically images of your brain. Based on those images, we have basically a GPS for your brain that we take, and it tells us the exact spot we need to go to, and it spits out coordinates, an X, Y, and Z coordinate. It tells us, here's where we want to go, right? Well, so the imaging tells us we want to go there, right? Well, how else do we confirm that? 2 other ways. One, we listen to your brain. That's when we wake you up. We listen to your brain. Your brain makes different sounds. It sounds like static, but as we're going through the anatomy, different parts of the anatomy make a different sound. So then we know we're in the right spot. Different targets make different sounds. That's the second confirmation. So we've got pictures, we've got what we call microelectrode recording, and then thirdly, we test you intraoperative. So all those things that the neurologist makes you do, we come in and do in the OR, in the operating room. We test you. So those 3 things, if those all check out, we're pretty darn sure we got it in the right spot, right? So that's huge. So that's why you're awake. But what we realized, or what Dr. Avicias, for instance, has realized, is you don't need to be awake for some of that stuff. You'd rather be asleep. We'll just wake you up for that 15 minutes in the middle and then put you back to sleep, right? And so that's how he's doing it, which is new for our area. We hadn't had people that were awake and asleep. So that's new, and it's proven very beneficial. And then this is the programming that I talked about. So you're initially going to go in and we're going to look at all those contacts in your brain and see which contact's best for you. That's a longer appointment, the first one, because we're going to be off meds just for that appointment for, that 4 hours or whatever, and see how DBS worked without the meds, right? And so to your question, I kind of got off topic. You're off for those first 2 surgeries. When you're putting the lead in the brain, you're off meds for those, say, 3 to 4 hours. And then when your initial programming, you're off for those 3 or 4 hours. So maybe a total of 12 hours, but not the whole time where we're waiting by any means. That would be painful. Okay, so this kind of shows, I don't know if you can see, this tells too much, but this is kind of showing, this is what BrainSense looks like. So we have basically, it's an iPad that your clinician would use. And they're seeing these lines here, the little squiggly lines, and that is showing, it's called LFP frequency, local field potential, and that is what we're playing with to try to get your symptoms to minimize. So you can see by us increasing different factors on the DBS system, we can get you from A down to B, or the second picture. So here's another DBS off medicine. So this is a patient that's implanted. We've turned him off. Now we're going to turn his DBS on. And you can see how he does.
Joe, we're getting extraneous images again.
Oh, you are? Mm-hmm. Let's see here. Might need my text expert here. Don't know what's causing that. Is it showing? What's it showing? Other slides or?
It's showing the previous slide plus this, and then this one big. So there's a sidebar with the previous slide and this one.
All right. Do you know why it would be doing that?
Did the show on this one, it ended the show. Did it show the video you wanted it to show?
Oh, yeah, we're not on anything.
Okay.
Yeah, we're just on regular slides.
To stop. stop share, reshare real quick
Okay,
from the same.
okay. I'll talk to this while we're figuring out some technical things. So MRI compatibility is very important. So back in the olden days, we couldn't get MRIs with DBS systems. That's changed, and all the companies have spent some time. We all have different indications and availabilities. Medtronic, we can do there's different kinds of MRIs. There's 3T and 15T, basically how good the pictures we're going to get. MRI system or MRI 3Ts are compatible with Medtronic systems. Nobody else has that. So just depending on your center, some have 1.5 Tesla machines, some have 3T Tesla machines. But MRI is something that we invested heavily in because a ton and most Parkinson's patients at some time are going to need an MRI. So it was kind of a bad deal when you went and got the DBS, but darn it, now I've got DBS, but I can't have an MRI. So that's changed. So I think that's important to note that you can have MRIs now. The other thing is, here, go to the next. Well, I think I lost my, it's sharing, it's, oh, can I, it's just not changing up here now.
Advance.
Yeah, it's advancing, but not
Oh,
on your big screen. While we're waiting on this, anybody have any questions about what we've talked about? Yeah.
So that you say that you can have MRIs now, if you had if I had mine, but I'm now on 11 years. And at that point I was told I had to have a specialty MRI if I was gonna have one.
So
So
I'd have to look. Yeah, so the question is, somebody that has a DBS for approximately 11 years, can they have an MRI? Most likely, but before you leave, I can look you up and tell you an exact answer. But typically, anything post 2009, you should be able to have an MRI. With that said, and that's a full body MRI. We used to always be able to do the head, but this is a full body. So if you have any orthopedic issues, et cetera. And the other thing on that is, it's not just the equipment that's in your body, does the hospital or the MRI center have the right machines? They use these things called coils to take the pictures. Do they have the right ones? So typically, there's only a few hospitals in the state doing them. And unfortunately, there's none in Lincoln. The only ones typically doing it is Kearney Regional and Bergen Mercy and UNMC, or Nebraska Medicine. Those are the only three, for the most part, doing them. Because they have the proper equipment, they've kind of went through their system, talked to their radiologist, and they're comfortable doing the scans. Okay. But if you talk to me before you leave, I can look up at your exact implant and make sure it's not an issue. Somebody else have a question?
A couple of years ago, I had a trabeculectomy done in my left eye. So I've got a shunt in my left eye. Is that an issue with?
It shouldn't be, no. I've never heard that. I mean, that wouldn't cause any sort of an issue with what we're doing or the location that we're going in. Yep.
So
Oh, yeah.
is the new controller compatible with old electrodes?
Yes. So the new battery that has all the adaptive, yes, it is. Yep, so everything, well, I'm speaking for Medtronic on that. I can't speak for the others. Yep. For Medtronic, everything is backwards compatible and everything we release now is upgradable. So some folks, when they go in now, like you'll go to your doctor's office and they put this little sling over it to communicate. It will automatically upgrade the technology to our latest and greatest. And that's just something that we've made a corporate conscious effort to make sure everything is upgradable moving forward. So nobody is without anything that we come out with.
Does any other electronics interfere with,
Good question.
like if you have to go in for, say you're flying, so you gotta take the x-ray, they warn you down.
Yeah, we always recommend, so the old stuff all used to be magnets, so we had more issues with both going through airport security, going out of stores where they have those stealing, what do they call them, or shoplifting device thing. A lot of that's changed now, but we always tell you at the airport, it's good to just get one instead of going through their thing, just in case. The only thing that I've heard potentially is some very industrial magnets like that would lift cars and stuff. Sometimes people could feel some pulling. And then there's some precautions for welding on certain type. I'm not an expert in welding, but certain type of welding, there's different types of welding and certain types can interfere. Not that you can't do it, but we always tell you, go there slowly and try and see if you notice any pulling or anything like that. But with DBS, there's really nothing that you can't do, and that's one of the big things with it. All right, so this was something that I'll kind of end in. This is a story that was on ABC News with the ADAPT. So I'll kind of end. I think it's worthwhile to see. See here if it will go. Give me 1 second here. Does anybody have any questions while I get this pulled up?
Does the new technology help with speech?
No, unfortunately, no. And I will say DBS can actually worsen speech. So we always want to be careful about that. Yep. So that is a potential side effect of DBS. Not for everybody by any means, but it is a potential. Give me 1 sec here to try to pull this up and then we'll.
How about, what was the question? Never mind that.
Give me 1 second, folks. See if we can get it. I think it's worthwhile, or I wouldn't waste the time on it. I thought it was pretty cool that it's talking about a conductor that got DBS and how you want to. I'll let you. I've got it, but I just can't get it to play for some reason. It's right here.
Okay.
I don't know how to get access here. Okay. There's this. Any other questions? Anybody that have DBS that wants to add anything? Call me out on anything that not so true or better or worse or.
You were at my surgery. I remember you.
Yeah, yeah.
I was away.
Yes.
My family was.
That one, either one. Yeah, they're the same. Yeah.
My family was.
It's not, oh, there we go. My family was petrified when I said I wanted the DBS because that's brain surgery. My kids, my husband, they all panicked and I said, it's my body. I get a say. I say it goes. I did it. It was the best thing for me. When you're awake, you have no pain. You don't feel what's going on.
Oh,
there is no pain in your head. You hear him talking. You realize your surgeon is just a normal human being that's sometimes talking about their grandkids while they're in between something. And you hear him talking, and I mean, it's great. And I happen to know my, what do you call it, anesthesiologist. I knew her personally from church. So when we started talking about my pastor at one point, it was like, it's great. I would say, if you're afraid, there is National Geographic has a video of a procedure being done, and it's not all that scary. It's like, it really is a breeze. So,
How did it change your life?
how did it change my life? I got to the point where I was not walking because I couldn't walk a straight line if my life depended on it. I wall walked, had to hold on to something. And now you really don't know that I have Parkinson's. I've had my battery replaced once.
Oh,
Yeah.
I had my surgery originally in Lincoln. That doctor has retired and there isn't a doctor in Lincoln that's doing them. So I had to go to Omaha to get my battery replaced a year ago. And that, like you said, they put you out when they do the whole battery part. But even my battery lasted me 10 years. And I mean, it's a breeze. It's just this little square right here. And so it's no big deal, but man, it's changed. You know, and they said there's things that they won't say that it can correct this or that type thing. I used to have a lot of problems with excessive saliva, and that's helped immensely. And that's not one of the things that they will usually say will be affected by it.
How long did you have Parkinson's symptoms?
I probably had it for like 8 years, diagnosed for 8 years. But once I was diagnosed, I realized I actually had symptoms for 30 years before that. I just didn't know that that's what it was. And I was too young and I had young kids, and so you deal with it. Did you have a question? Okay. So I highly recommend it. But there's always, when you do the surgery, there is always somebody from Medtronic there. It's not just your surgeon. A Medtronic person is there with you.
Does this device, if you have like cardiac issues and you have to have put in a pacemaker or something, will that interfere with that?
We'll just, yep, we could put it on either side, the DVS. So folks that have a pacemaker or might have some cardiac issues, or they're just nervous that maybe they will in the future, we just put it on the right side. Yeah, but they're we just keep them a certain distance apart. It's usually like 8 centimeters apart, and then there's no interference between the two. But that's a good question. It is always something that we talk about and consider.
You know, there's so many times that you say
2050, and while there is no known cure, this new device may make life easier.
There we got it.
so close.
that was me.
Any other questions? Go ahead.
My husband's had DVS. He's got the adaptive battery pack, but he's on the regular pack. He participated in a sleep study UNMC had.
Yep.
Do they ever decide, or who decides if he goes with the adaptive part of it or stays the regular?
Yep. So good question. So there was a small group of people, 10 patients at UNMC there was about 10 patients at UNMC that were involved in a sleep study. So it was a sleep study that was done with UNMC and Stanford and Penn hospitals that we're looking at DBS and how it helped with sleep and how different sleep patterns may help, or it's not different sleep patterns, different stimulation patterns would help with sleep. And that's what you're referring to. And so it was a research device that those patients were implanted with. So that's the question. that research device at any time can be explanted and put a normal adaptive DBS. Everything's compatible. So that's a rechargeable device that your husband has. If at any point in time you want to talk to your neurologist, say, I don't want this anymore, I want to put this in, we can do it. It's not an issue. So there's been a handful of those devices that we've explanted now and upgraded to the normal market available device. That device did stuff. That was kind of the free device before we came out with this. It had a lot of this technology. The difference of that device versus this is the recording, the battery, or I should say the storage capability is greater. So that's why they use that versus the Percept device or the new one. You and the neurologist, you have to just tell them that, hey, is there any way? And they'll more than happy. Now that they're done with that study for your part of it, you know, like I said, we've done it before. It's just a conversation you need to have with your physician and see, is it worth the risk, just like any surgery risk to do that. Yep.
I think I got it, Joe.
You got it? All right. So we'll kind of end on this. This was something that was on the news that I think kind of talks about
There's some of the 1 million people in the US living with the disease, like Rand Laycock, who has found a renewed passion and purpose and a decade into living with Parkinson's. Rand Laycock is a man of many talents, including conducting music. Another, perhaps more hidden talent, is managing the movement disorder Parkinson's disease for the past 10 years. And as the former music teacher's tremors and freezes worsened, he worried he would have to stop what he loved the most, bringing a score to life. I would imagine that your Parkinson's diagnosis was difficult for many reasons, especially so because it would impact your ability to teach and conduct music.
That became a real concern of mine because I thought, well, am I going to be able to conduct or not? It was getting to the point that I would start rehearsal and I'd be kind of frozen. And, you know, this was starting to get embarrassing. I thought, am I going to have to give this up, which would have killed me? Luckily, the cavalry came at the right time.
Rand's White Knight, a newly FDA-approved adaptive deep brain stimulation, or DBS device. Electrodes implanted in Rand's brain send small electrical signals based on his brain activity, a sort of pacemaker for the brain. The device provides therapy for the misfiring signals in real time.
It's always in my right hand.
Here's the device turned off, and then turned on. Instant relief, and a steadier hand for conducting.
Each patient's reason for DBS is different. It's going to be to help their tremor, to reduce their medication burden, to reduce the medication side effects. It's been tremendous. It doesn't eliminate the problems, but it makes them much more manageable.
What does that feel like emotionally?
It made it so that I wasn't thinking about Parkinson's all day long.
That had to be nice.
Oh, it was wonderful.
Wonderful indeed. Rand had his surgery at the Cleveland Clinic, which was involved in the research to develop these devices and was one of the first sites in the US to implant them. And since then, Rand is back at the gym. He's working out, getting stronger. That will also help with his Parkinson's. Guys, he said he feels like a cloud has been lifted. Really, I bet he does. Okay, well, thanks very much.
All right, so I think that's a good way to end it. Anybody have any additional questions? Yeah. Yeah, very true. So that I don't have an answer for. I don't know. I don't know why that is the case. Good question, but I don't know the answer. Because, you know, the interesting thing also on DBS is we don't really know, this kind of goes into that. We don't exactly know why it works. We know it's disrupting those electrical signals, but we don't have we just know it works. And it was found accidentally when it was found 30 years ago. But I don't have an answer to that, to your question, and I can't say that we even know exactly why it does work. Except that we know by disrupting those electrical signals it does. So sorry, good question. You stumbled me on that one. I haven't had that ever asked. Any other questions? All right, well, thanks you guys for all your time. I know I spoke a little longer than maybe I should have. And thanks for being patient on the new presentation as I kind of fumbled through that, all right? Is it too long? Just can I get a little feedback on it? Is it too long? No, it's okay. Okay, thank you guys.
Thank you so much.
You bet.
We really appreciate you coming, Joe.
Absolutely.
And keep up the good work. Medtronics. I think I need my notes. I've got a couple of announcements. First of all, at the table, helping Diane is Cheryl. Wait, Cheryl. She's MacArthur. Her husband, Bruce, Bruce has volunteered to be our new treasurer, so we really appreciate that. Johnson retired, I guess that's what we're calling. And so we are happy that this is really, don't forget on the table, the paper, please write down any ideas that you have for upcoming presentations. The next thing is this book by Ray Dorsey and Michael O'Coon, and I've finished with it. I actually listened to it on audio, and it was good. This part of the book, the first part of the book is what you actually read. The second part of the book is acknowledgements and resources and all that kind of stuff. So it's full of good stuff. I'm going to actually give it to Jim, and he can put it in our library. And if you want to borrow it and read it, it'll be there for you. Sally has brochures, and we have cards on the table. I was so excited. I went into the place where I get my hearing aids, and on the table there were, in a nice little container, were a stack of brochures from our Parkinson's support group. And so that was really good to see. So please, if you have a place you can take brochures and read them so people can find out about a group, that would be wonderful. Any other announcements? Our next meeting is November 23rd, and Ruth Davidson Hahn will be with us. She has the Dance for Parkinson's studio, and she can tell you all about the exercise that you can get from her business. A lot of people really love that. I laughed and said, I don't know how to dance, but she said, you don't have to know. So it's available. You have to do it. Yeah, no excuses. Thank Gunter for setting up the Zoom, and happy that people on Zoom were able to join us. And Sally has put out some water and some coffee, and I think I see some cookies over there. So after we finish here, we'll have you take a little break, and then we're going to divide into two groups, care partners and those with PD will stay in here, care partners in the kitchen. And Jim, he's our librarian, and we really appreciate him setting up the table with lots of resources. So please take a look at those and see if there's anything that you need or want. I think that's it. So thanks for coming. We hope to see you next month. We won't have a meeting in December, but we'll start back after November. We'll start back in January. Thanks again. Thanks, Joe.